You said, David, you don't want to miss this case. It's very exciting. I don't know if Herms and I find this very exciting because we have Dr. Ziad Ali in the room here, which makes us
annual tools.
201.
Tool 2. We just push and pull.
And we do what we're told.
So I won a bet a few years ago, and that's how we got to this place. So they're going to be the robots today.
That's all we do.
Tool 1 and 2.
But with an element of real seriousness, the reason is because what you're going to do is guide intervention with advanced imaging.
Mm-hmm.
Okay, I mean, we've got physiology on this, outpatient physiology. We know that this is a lesion or stenosis that needs to be fixed. But now we've made the decision it needs to be fixed based on physiology. Now we're going to make all of our decisions, or Ziad's going to make all of our decisions for us based on advanced imaging. And I think this is great. I hope this is a real learning experience for people who are just getting into imaging and those who have been doing imaging but don't do it the way you do. Why don't you put up the slides? Okay, this gentleman is 81. He had PCI many years ago, and one of Ziad's tasks today is to tell us what kind of stent it is. We don't know. So PCI many years ago, to the right, multiple risk factors for heart disease and some bleeding-related issues in the past. Recently presented with symptoms of chest discomfort, had a stress test. The stress test suggested a right coronary artery culprit, ischemic culprit, and cardiac catheterization was performed. And there was also a very critical LAD. Go forward. Calvin Louis did a spectacular job fixing the LAD, and we just reserved the right coronary for today. You can see the right coronary. We believe it has a long area of stent in it. And I can't tell really, Ziad, if the stent goes all the way back to the ostium. If in the one view, it kind of looks like the stent not only goes back to the ostium, but maybe there's a stent or maybe there's calcium extending all the way to the ostium and into the aorta.
Yeah.
So it's all yours.
So I think this is an amazing opportunity to use enhanced angiography. So most of us have this in the lab. We don't use it. Stent boost, clear stent, stent viz, device detection. So the first thing we're going to do is going to just go in with a regular balloon. We're not going to inflate it, and we're going to do stent boost on the artery to determine exactly the questions you had. Because the stent boost will identify stents, but it will also identify calcification. So we're going to learn about the morphology and the stents just by doing stent boost.
Okay. So do you want to bet? Is there stent all the way to the ostium or no?
Yeah, panel. Did you guys see the picture? Does it look like there's stent all the way back to the ostium?
It's hard to say. I think it's probably calcium, at the very ostium, but I think it's hard to say. It looks maybe like it's just proximal to mid.
Okay.
Question.
Let's find out.
Are there any clues to tell us? Any clues to tell us whether that's a fractured stent?
Not yet.
We'll know.
Okay.
But you'll know in a few minutes.
Okay, so I'm going to do stent boost.
So that's another great thing about enhanced angio, Mort. They will tell you whether you've got a fractured stent much better than intravascular imaging. Because the intravascular imaging definitions don't really work when it's on a bend or if there's the IVUS or OCT is jumping, because it's defined as no struts on one half of the stent during a pullback.
And as you can see also, just because I'm a little bit of a broken record, we are using Protego, so we are going to be protected with all of this stent boost and everything else. Okay, here we go. I'm going to do a stent boost.
Okay.
Very nice.
So you learn a lot from this enhanced angio or stent boost. So the first thing is there is no stent to the ostium. The second thing is that this is a first generation drug-eluting stent. You can tell by the stent design. You can also tell, given the guiding catheter, that this is a pretty small stent in a really big artery. Then the last and probably most important thing for Dave and Herms is do you see where the calcium turns upwards? That is the ostium of the right coronary. So all of those things that we have to use all these difficult techniques to figure out, are we the ostium, are we not? You can do it all by this enhanced angiogram.
That's great.
All right, next
I love
step.
that.
Next step.
So the second question is there a stent more distally?
And you think this is a cipher stent?
I think that's a cipher stent.
Okay.
Yeah. Based on its
About
design.
3 of them.
And so now if we go more distally, right around the crux and do another stent boost, we're going to learn whether there's a little bit more distally. You got to get the, so
Get the
in order
balloon
to
down.
activate any device detection at the moment, you have to have the 2 markers for the balloon. That's how it determines the region of interest. Perfect. Okay, so you've answered your question again. So around the crux, that's de novo atherosclerosis with no stent. Your calcification is eccentric, not concentric, so you shouldn't need any advanced lesion preparation. You just need a non-compliant balloon or even a semi-compliant balloon to dilate it, and you've got your plan.
Okay, so what's my next step?
So that's a great question. So the main thing to do here now is how you're going to prepare your osteal lesion.
That's kind of where I was going.
Right.
What you always say, you got one shot at doing it right. Is that correct?
If you're going to use a DCB.
If you're going to use a DCB, you got one shot at doing it right.
Right. Okay. So why do we say that? The reason is most well, let's do this on imaging.
Yeah.
Okay.
Let's image next.
Right.
So while the guys do this, let me explain what we've learned from our intravascular imaging of ISR lesions. So most neointimal hyperplasia is not completely concentric. It's usually a circle where one part of it is thicker than the other. And if you use a regular balloon in that tissue, just like simple applied physics, you'll always tear the artery at the point of least resistance, which is the thinnest part of the neointimal. When that happens, the neointimal tissue recoils like a rubber band, and then you can end up with a ball of tissue on one side. So if you end up a ball of tissue on one side, it's a fixed obstruction.
Okay.
So it's not a good candidate for drug-coated balloon.
He and I are going to switch spots because these guys are stuck with me all the time. They don't get to do interventions with Herms, and he is really simply one of the best.
He does the big interventions with the big stents.
Dave, quick question. Mike,
Yes,
Lim and I, Ziad, are wondering, why do you have to put the balloon down to use stent boost?
Because in order for the X-ray, whatever system it is, to be able to identify your region of interest, it looks for those 2 dots. You can actually trick the system into doing it with an IVUS, but you cannot, as far as I know, on any system at the moment, force it to look at a segment. In fact, we had a discussion with Philips yesterday that they should do that, especially given its importance in calcium lesion modification.
Great, thank you.
Let's go. Help me out.
So I think if you're planning for a DCB, it's really important not to end up with an eccentric asymmetric neointima. And that's where it's important. I think there's a lot of value in cutting balloons to make very controlled dissections so that you can actually have cuts on each side so that you're kind of spreading the fan when we use an NC.
Going there or no? Okay, wire.
So, David, what, in your estimation, what is the mechanism of restenosis of this stent? Is it under expansion? Is it recoil? Is it calcium at the ostium? What is the mechanism here that you're seeking to?
Ziad answers all the tough questions. Okay,
That's not fair.
We're damped.
But given that this is a stent from 2009,
Okay,
if you just follow the data, this is much more likely to be neoatherosclerosis than anything else.
And we think there's lipid there, correct?
That's this is going to be a lipidic lesion.
Yeah.
We should see a dark hyperattenuation on the IVUS.
So our IVUS is not going past there. So we'll do a first IVUS run, but obviously we're going to have to treat that non-stented segment that we looked at on Ziad on the stent boost. You see where we were not, it's not advancing past?
Yep. So so we just went live on our IVUS.
Okay, ready for it?
And this is the Avigo Plus. So we can do fast pullback. We can do full pullback. but I think usually on the pre, 1 millimeter makes sense. So they're pulling back now. It's already pulling back. He's doing manual.
We're doing Rizik speed pullback.
Okay. Want to give a little flush, guys?
Flush.
Yeah, flush.
Thank you.
So what are you seeing right now? You're seeing, are you guys, I think it stopped pulling back, right?
No, it's not. It's pulling back.
Okay. All right, so this is your tissue, right? Dense tissue. You see how it's so dark?
Uh-huh.
That dark, that's classically lipid, very hyper attenuated plaque.
Now I'm outside the stent.
Now you're outside, you have X, that's a calcified nodule. Do you see it pulling
Yeah,
in?
beautiful,
Yeah.
beautiful.
And it is actually affecting the lesion. So when we'll stop this and we can run through it together.
Okay.
All right, so if we just run through this from the distal, you see there's some eccentric calcium near the distal.
Herms, take that out. Okay. Careful, careful.
Continues
Arthur,
to be eccentric.
I think Arthur's point was that doesn't the IVUS determine the mechanism of
Yeah, I put the IVUS
restenosis
back.
here?
Yeah, just see if you can.
Yeah, do it.
Oh, absolutely.
Better?
And so
Got
here, do you see that right here, right? This, which is the tightest section, this dark stuff that's on the inside, this is the, actually, to be honest, this looks like neointimal hyperplasia.
Uh-huh.
If it's darker, it's usually lipid, but this
we
this
good?
gray speckled stuff is neointima. So the mechanism is actually neointima. The rest of it, like
Yeah.
down here, this is calcified neoatherosclerosis. You can see it's so dense that you can't see the stent behind it. And then as you come up to the ostium, which is right here,
There you go.
right there. Do you see the calcified nodule at 12 o'clock?
Yep.
Yeah.
Okay, there's another calcified nodule or spicule coming in from 3 o'clock. Okay? And then as we come back more proximally, there's one more calcified nodule right at the ostium. And so if you go back and you look at the device detection or the clear stent, you see the same thing. So
All
you
right.
can see those.
So I got a question. I'm not seeing 2 layers of metal there. I'm seeing a single layer of metal. Now, I think when I see 2 layers of metallic DES or metal in a vessel, I automatically start thinking about DCB, and that's my default. We have 1 layer of metal. Now, you're the expert on the comparison of DCB to a second layer. What's the calculus here?
So the calculus comes from the Illumian 4 sub-study for in-stent restenosis. For a single layer of ISR, your event rate for a second layer of stent is about 7.5% at 1 year for single layer. And if you use a DCB, it's about 15%. So DS for repeat TVF for a single layer ISR is a superior modality according to indirect comparison at the moment.
Yeah.
Given on top of that this is a very old stent,
Yeah.
right? That really pushes you further towards a DES.
Yes.
So as much as the reflex is, this is in-stent restenosis, and we got this great new toy called DCB and the data on that. Now we're really dealing not with things that were in a lesion that was in the clinical trials, right?
Yeah, that's right. I mean, the clinical question remains unanswered is if this patient has a subsequent failure, then your options become more limited.
You really limited the option.
Right, but if you remember, this 2-layer ISR group in Agent did extremely well. In fact, they did a little bit better than the single layer.
Uh-huh.
So we do have a treatment modality. So I think that in this situation where you can get a big MSA, the data would still favor DS.
Yeah. And I do think, the biology of this atherosclerotic sort of
Absolutely.
obstruction is so different than intimal hyperplasia. So,
No question. There is a focal segment, that very, very tight lesion at the ostium, interestingly, is actually neointimal hyperplasia. I thought it was going to be neoatherosclerosis, but if you look at it and you go very proximal, which is right, sort of here, this area.
uh-huh.
This area it's very tight. This is actually mostly neointimal hyperplasia.
Yeah. Okay.
So I think we should take. Correct me. I'm not supposed to have any original thought.
Yeah.
We got to get that downstream open because we couldn't get our ultrasound. So why don't we go back with our 2
Yeah, yeah.
balloon and dilate this? You want
Yeah.
me to dilate the osteum too?
Yeah, I think if the plan is for DES, there's absolutely no downside to doing that. What we will do and show it live is when you dilate the osteum with a 1-to-1 size non-compliant balloon, we're going to do it on clear stent. Because what we're going to see is exactly what I was talking about during the lecture. Are these nodules a marble on jelly or a marble on rock? Now, based on the clear stent, it looks like it's a marble on rock because there's so much calcium. But we won't know until we inflate the balloon. If it gets pushed out of the way, we put a stent. If it doesn't, we've got a shot.
So Ziad, this is Tim. This is a good chance as they're doing this can you talk about the relative merits of IVUS versus OCT in this situation? And you have everything available in your lab. In this case, what would you do? What would you do if you had it? Would you do OCT or would you do IVUS?
So that was actually a discussion point as we came in. And just speaking plainly, OCT is a superior modality for ISR. The reason is it's much easier to see the layers. It's much easier to see the thickness of the calcium, and you don't get the shadowing effect.
But what does the osteum do?
Exactly.
Okay.
And so the problem is that in this situation, because you have an osteal lesion, it's very, very hard to clear the artery. And so as a result of that, we decided to use IVUS.
That's fully profiled. That's nice.
Yeah.
This next area is where, right?
While we're ballooning, I have a question for the panel. In cases where you have 2-layer ISR and you have the availability for both brachytherapy and DCB, are you guys staging the procedures? Are you doing DCB and brachytherapy at the same time? Is there any data, and how do you think we should kind of manage these patients?
I think it's on expand.
I'm not.
If you're not, do a boost, guys.
Upper right.
Okay, boost. Here we go. Ready for a boost?
Yeah. Oh, doesn't look bad.
Yeah. There's a little bub.
Yeah, a little bubble in there.
Yeah.
You are a little damped.
Yeah, I'm gonna get up. Let me get a little.
We don't have brachytherapy available, so we do DCB, but it's always, it's in our algorithm of, I don't know where those centers that have both, what they do. It's a very good question, but it's always, these are the patients that come back, and you have to, you have to keep attacking these vessels until you win the fight. And so anything we can do to, we use everything that we have available, and then we refer for brachytherapy. What do you do?
So stay off floor for a second, Tim.
So, I think I had a patient that we were referring for brachytherapy and DCB at the same time, so I think it's tough because, I don't know if it'll change the effects of brachytherapy or change the effects of the DCB depending on the order
Okay,
in
this
which
is
you do
beautiful.
it. I don't think we have
Absolutely
data to kind of support
You
either
have
way.
one very short segment of concentric calcium. You see the calcium on both sides at that spot?
Yeah.
That is your culprit, right? And so you can see what the problem is on the advanced X-ray.
Yeah. It's beautiful.
And how high were you guys up there?
12 atmospheres.
Might go a little higher.
We're using just a compliant balloon right now.
Yeah. A little concerned about that.
Yeah.
I'll try it one more time here.
Yeah, it doesn't look like we're.
Nope.
It ain't gonna work.
One other thing about OCT is just, it looked like you had a really critical, almost subtotally occlusive lesion up top. And I think if you put the catheter down, it'd be really hard to opacify enough with a contrast to really exclude the blood from the vessel to be able to see without a lot of swirling artifact. That nodule or that eccentric, that concentric lesion you have there too might have also been another choke point.
There it comes. I'm just gonna come back.
Yeah, these are caveats of OCT. Although, using a 1.5 or 2 balloon to make some space is, it's not cheating. So if you need to get clearance.
Yeah, sure. I was just saying up front as you're making this decision and illustrating.
Okay.
So that's actually a good sign.
That was easier than I thought it was
Right.
going
So
to be.
you see the wires in the middle, and there's contrast on either side of even this very small balloon. So when we go with a big NC balloon, this is probably going to be a marble on jelly.
Okay, so and the The other possibility would have been if you had a banana-shaped balloon and the wire was on one side of the balloon.
Exactly.
And for you, that means
a marble on rock.
A marble on rock.
rock.
Right.
Okay.
All right.
All right, let's get that out, huh? I'm not sure we're going to get that IVUS down with that resistant lesion there.
So do you want to shock that lesion in the mid?
Let's use an NC first or something.
Yeah. How big?
How big?
So do you think we can get our IVUS back in there? If we can't, then I'm gonna size it from proximal.
We're getting stuck. Yeah.
Okay, so let's go as distal as we can. I'll find any segment of normal artery or normal-ish artery anywhere I can. I mean, probably this is the most. So turn on the ALA.
Yeah, I did. You and I always do.
Yeah, I mean, you can use a 3.5 balloon here.
Okay.
Really?
3.5 NC?
Yep.
Gianna, how are we doing up there? Last ACT? You know, we like to have anesthesia to do conscious sedation for these cases at SIF, so we didn't have to think about it. Gianna is wonderful, and she's a veteran, and she just does a spectacular job, so it's one less thing that Herms and I got to think about. Thank you, Gianna. Yep. Take that for me. Ditch it.
David, I noticed that the compliance chart of the non-compliant balloon is right at your eyeballs. Do you use that?
No, I don't look at that. Hell no. I mean,
Good.
no, I don't.
Good, because I think it belongs in the wastebasket.
Yes. Thank you, David. In the wastebasket. They know that that's not something I have right-sided neglect when it's on my right side.
And the whole point to the audience is those are what the balloon achieves outside the human body, completely,
right. Not in a
irrelevant,
in vivo confined space.
And even then, it has a 33% standard deviation.
Did you go negative? Yeah, you did.
All right, you want to start down there? That's at the edge of the other stents.
Yeah.
All right, so this is a 3.5 non-compliant.
Yes.
Up we go.
Oh, baby. Oh, resistant lesion there, don't we? We're going to have a dog bone on this.
We are going to have a dog bone on this. Ziad, any problems starting smaller on these? I know you went right to 3.5.
No, I mean, I think the question is about safety, but I mean, these are safe lesions based on what we're seeing on the IVUS. So, there it goes.
Boom.
And so, this is exactly why we did the stent boost.
There we go. Bingo.
How high a pressure did that require to get that to yield?
About 8. And I'm generally looking at the profile. Here we go.
That's
the ball game.
This was that culprit, right?
Boom.
There it goes.
Nice.
All right, at least stay right there a minute. Stay right there a minute.
So come back a little bit and do another boost.
Hang on. Beautiful.
Looking good.
Do you want me to come back and we'll boost it right there?
Okay.
No boost?
Go do it with the balloon up. Let's do it with the balloon up.
Oh, look at you.
I like this.
I like not having to think. WWZD. What would Ziad do?
I don't know what's going on at the proximal end of that.
This is the nice thing of having a Protego. You don't have to worry about this.
I'm not even thinking about it.
I mean, all right, so there's your profile. So you do have an area that's in the middle that's still constrained.
Yep.
And proximally.
Yep.
So, I mean, that's what, after we do this, we re-image, see if you have any lesion modification that needs shockwave.
You want to do the stent?
Yeah, let's see right in there. All right.
That's great.
Boom, boom.
It was 2009.
Love it.
So let's do this one on boost, guys, because now
Up on boost.
yeah. So no, when you do the proximal osteal lesion, because that's going to tell us the marble on rock or marble on jelly. Yeah.
Beautiful.
Ziad, is it usually your process to stent boost whenever you use these NC balloons just to look
You
for
might see the
waste?
pressure
Absolutely. Absolutely. I mean, it tells you so much information. So you see this? I mean, you answered the question. So when Herms is going to do a stent boost here, we'll point this out.
Oh, shit. Sorry.
You got to go back up.
Here we go.
Wait for a sec till he's up.
Okay.
Yeah.
Wait on that. Hang on.
That was, whoops. I have said worse live.
Stent boost, upper right.
I got it there. There we
Okay.
go.
So do you see how the wire's right in the middle of the balloon where the calcium is? This requires no more lesion preparation. Because if the calcium's unprepped and not cracked, the wire gets pinned to the calcium. So you've got your proximal marker right at the ostium of the right coronary. So you already know how to do your procedure.
I mean, this is like simplifying. We started this case off thinking of a certain complexity, and imaging has simplified this beyond anything that we thought when I showed you this case last week. This is way simpler than I thought we were going to have.
I think there's only one clinical question left before you stent, and that's that mid lesion that wasn't really yielding, and that's where the value of your IVUS is going to be.
Okay. We're going to do another IVUS run.
Can I just ask, how high a pressure were you taking the balloon close to the origin there? Because honestly,
I got to tell you something.
It doesn't look 3.5 the way it looked 3.5 when you were doing it in the mid vessel. It looks like it's constrained kind of concentrically there to me.
Right. I go up to profile. Okay. I don't look at the meter, if you will, until I start to see it profile. And I went to 12 every time. Okay. The one I went to 8, but I eventually went to 12 on it. I went to 12 atmospheres on a 3.5 NC on every one of these.
Thank you.
Did I answer the question the way you were thinking, Doug, or no?
It's Doug, and I thought it just looked like the balloon was narrower in caliber because it was constrained by the lesion close to the origin of the right, where it didn't in the mid-right. So my suspicion is that you still haven't really expanded that.
I'm worried about that as well.
Jana, how are we doing on the ACT?
Doug,
Thank
I'm worried
you. What
that
was the
this
last
is
one?
not going to fully expand if we don't use shockwave or some kind of lithotripsy at the beginning of some kind of plaque modification at the ostium or more proximal
Tell me
segment.
when you want me to let go.
You got it. I got
So I disagree, because the proximal segment, since you've got the wire in the middle and contrast on both sides, any calcium that's there is already fractured. So the question to go back with shockwave would be to create more fractures if you've already created fractures, and there is no evidence for that at the moment.
Oh, look at how nicely that went. That was smooth.
I'll go down into this other one.
Ready?
Yeah.
Okay.
Wanna go live?
Ziad, you want to go live?
We're gonna image. I'm not gonna do manual. Let's do auto, right?
I don't have it on the sled.
You don't have it on the sled? Okay, so manual it is. All right, so I'm gonna start recording. Come back slowly. All right, so you see the calcium fractures, right? One at 9 o'clock. There's your stent. You can see your stent now.
Wow.
Okay, so actually, interestingly enough, like we discussed, is mostly neointima. Sorry, atherosclerosis. So eccentric calcium at 9 o'clock. Okay, so that's just advance forward a little bit. So, and then come back slowly, because that was the area that's not really expanding right around here, right?
Yeah.
Interestingly, there's not that much calcium. It's all eccentric on one side. Come back here, big fracture. That was a fracture at 6 o'clock. Advance something. I want to show something to people. Okay, right here. Do you see how the artery's an oval?
Yeah.
Okay, the reason the artery's an oval here is because of bias. So you've got a very soft part of the artery, but the stiff part of the IVUS, which is creating this like a coat hanger effect. That's why it looks like that. Lots of fractures. Are you near the ostium now?
Yeah. I'm about 10 millimeters away.
Okay. There's your new intimal hyperplasia. So just advance for a second here. Okay, see all that tissue that is coming from, say, 3 o'clock all the way till sort of 1 o'clock, and then there's a little gap.
Yeah.
Do you remember I mentioned that when you use a non-compliant balloon, you tear it eccentrically in one spot? That is exactly what happened. Yeah. Okay, so you got to tear at the thinnest point, which happened at 2 o'clock. So you have a ball on one side. You can't DCB those.
Turn it off.
You have to stent them.
Okay. Off imaging.
Can you get the ostium of the nodule?
For a second.
Okay, great. So there's your nodule.
Nodule's right there, 12.
Yep, come back a little bit.
Come back.
Yeah. So there's your nodule. So it's recoiled back in, but it will expand. So it's a marble on jelly still. So when you stent it, it should get pushed out of the way. Yep.
Off imaging?
Yep.
Okay.
Hang on, let me do it this way.
Good.
Okay, now go ahead. Going easily?
Yeah.
Okay.
I think we just had it stuck there.
Yeah, right.
It's pounding it into that lesion. Okay.
So the frame on the IVUS right now is the problem. That's the one that didn't yield. So your options are to try a cutting balloon here, to go back with the NC and go with higher pressure, which is probably what I would do next.
Yeah. Give me a new 3.5 NC, please.
And so you can see why it's eccentrically
Like a 15,
doing this, because the calcium is
15.
fractured only at 6 o'clock. And so as you expand this, that's why you're getting a dog bone on the other side.
How much time do we have left, Fred?
6 minutes, 47 seconds.
Oh, okay. We may have to do our work off camera in 6 minutes, and then we'll ask you to come back just to see a finished product, okay?
All right. I'm going to go down the panel because Ziad's right. I don't think Dave Cox is smarter than Ziad. But I'm going to go down one by one, and I'll tell you what my bias is. At this point, from what I've seen on that IVUS, I'd be whipping an IVL out and start cracking as much as I could. Now, that may be wrong, but I'm curious to see if I'm the only one on the panel that would do that. So the question is, at this point, and you can roll it if you want, but is it non-compliant or cutting balloon versus IVL? One answer. IVL. Doug?
The NC balloon is sitting there, I'd use that.
You'd use that at a higher pressure.
Higher pressure first, and then consider IVL if it doesn't yield.
Tim?
IVL.
Just a tad.
Who's next? I can't see.
Sudashna. I would do IVL. We've tried an NC balloon, and I agree you could go higher, but I don't think it would hurt to do an IVL and get more fractures.
Okay, who's next?
We'll see.
I would do high atmosphere NC balloon dilatations.
Okay. Arthur?
Cutting balloon probably, and then
you just broke it.
consider IVL.
Okay, and on the very end, is that it?
Yeah, I would echo Arthur's thoughts, I think, in an effort to reduce just time of ischemia and barotrauma and allow some uniformity.
Interesting.
Well, it just broke, guys.
We just saved how much money?
So the high pressure NC broke that calcium.
Should we just come back and bomb it just a little more approximately? I still want to see that.
So how high are you going here, David?
It broke it at 8, and then I went to 12.
Okay.
So I was just doing it a second time. It's profiling. It's giving me visually full profile at lower atmospheres than 12.
Think I got it?
I think we do.
Okay. I
I'm
don't
going to
think
hit
we
it one more time or
Let's
no?
go it one more time. Just
Doug, you
No,
were the
Doug,
one that
I'm
made
gonna
the
stent
concern
it.
about the balloon profile proximally, and that was the area that I'm most concerned about. I figured that mid thing would crack as it is. So it'd be interesting to me, Doug, to see what happens as they dilate here higher, and if that balloon expands or not. We'll see.
I think it's
We're
interesting
getting
to
full profile at 8, but I am going to 12.
I think the whole process that they've done, though, so meticulously looking first with the angiography and the kind of stent boost, showed that probably when the stent was initially inserted, they did not use intravascular imaging, and it was underexpanded at that time. The vessel deserves to be 3.5. That was probably put in at 2.5, 2.75 or something by the profile of it. So it's got sort of an inherent collar in there that's now enshrouded in calcium and was probably never fully expanded to start with. So they're fighting against this. It's calcium on jelly on chicken wire mesh, maybe.
Great point.
Maybe in reversed order of some sort.
There we go. All right.
Well done.
I think we missed the ostium, though.
Yeah, I do.
You know, I think there's parts of the artery that will expand to higher pressure, but there look to me several places where it's circumferential calcium that you're going to need IVL, and as long as you have multiple pulses, I think IVL is faster because you could just do the whole vessel and get there quicker.
Guys, we have a great question from the audience. Please, sir.
It kicked it out.
Any experience from the panel about open NC balloon, the ultra high pressure balloon as an alternative, cheaper alternative to IVL?
Careful.
Those balloons that go up to 40 atmosphere.
So we had trouble hearing a little bit up here. Was the question high pressure balloon versus IVL?
The high pressure, the ultra high pressure. The one
ultra high.
All right. That's a great question. Ziad, why not an OPN to 32?
But honestly, I get more reimbursement with the Shockwave. So the OPN balloon I have to pay for. The Shockwave I get paid for. So if you have a device that's extremely safe, that is proven efficacy, that you know is going to fracture calcium, and the hospital and the physician gets paid more, I'm going to use that one.
You know what happens? We really opened it up, so it's.
And if you're going to use OPN, remember to go down a half size.
Push it into the ventricle.
We've been using it for double layer ISR, where really, to be honest, Shockwave doesn't work well. So when you put a big layer of carpet in between you and the calcium, that's a big problem. All of the energy gets absorbed because there's very high impedance in that area. So in those situations, OPN is very, very useful.
Okay, great, thanks. You had mentioned that in your talk, but it's nice to hear it again. 2 layers of stent, IVL may not be the best option. All right, what do we got, Herms?
Run it. Watch this. Did we send it? Was that a floor or a cine?
That's it. It's a setting.
Run that. Look at we got procs there. Interesting.
Yeah, I mean, we're going to stent it, right?
Yeah. No, I'm just saying it seems like it's going into the stented segment, though. You see that?
Yeah.
All right. Based on your advanced imaging, what size metal are we going to use? Oh, let me check. I mean, we're going to be very precise here. We'll work. How many minutes we have left, Fred? All right. So Ziad is going to use the imaging we got to tell us exactly what size stent. I think the take-home message, something long. I think the take-home message is this was all determined. Every move we made, every step we made in this case was determined by advanced imaging. There wasn't one thing we did that wasn't advanced imaging.
Yeah.
So 3.5, right? So your EL to EL here is 3.48. I don't know why I can't get the LA to work. So you're right around 3.5. I think that's especially, my suspicion is you're going to connect this to the old stent,
just give
right?
us a stent or something to get in here and we can push this
And so your a 3.5 is going to be an optimal size. Distally, you have a little space. It's actually bigger, which means tells you 3.5 should be in good shape.
I've been turning it anterior like crazy.
Yeah, I know. That ostium is.
And how long of a stent?
I think we'll just get a
Unfortunately,
stent,
I can't tell you that because they didn't use a
What's
motorized pullback.
Quickly.
So we'll have to do it by engine.
3548.
Yeah.
3548.
Perfect. And then you want us to just go down to the...
I've connected to the old stent, I think.
That's what I think, too.
You need to drink here.
You know, and I pushed it down to get it out, and it wants to go into the ventricle.
You know, the Amplatz behaves differently than a regular catheter. The more you pull back on these, the more they dive in. So the movement to disengage an Amplatz for our fellows watching is not a pull, but it's a push, just like that. Did you see what I just did to disengage it a little bit? It's a push, it's not a pull. The more you pull, the more they dive in. So, and for those of us who used the the bulkier, less forgiving ALs back in the day, you know, we had to learn this, a lot of dissections, right?
Yeah.
Yeah, both coronary and orthocoronary. All right, Dave, we're at 2:10. What do you want to do? You want us to watch this or?
Go. No, we'll come back to you. We're just putting stents in now.
Okay.
There's no thought to that.
All right, sounds good.
Okay, so can you see the image? That's our last picture. Okay, really fantastic. Can you show the IVUS? I want to show what Dr. Hermiller did. We were trying to hit the ostium right on, and if you look at that, can you do that still frame IVUS? He literally got it with one cell in the aorta. One cell.
Yeah,
that's
fantastic.
Precision. That's perfection. Vessel looks good, well expanded by IVUS, et cetera. And then last but no means least, no radiation to the operators. One of the circulators got a little bit, but no radiation is the goal. But again, zero radiation with all the stent boost and everything we did, zero radiation.
I mean, as we start relying on these more, that makes it even more necessary. If we integrate all these tools, you don't want people to avoid using enhanced angio because they don't want to send air fluoro.
Yeah.
Right. That's not good for the patient.
Yeah.
Final word, Herms.
No, this case just demonstrated to me the synergy between the, you know, using the fluoroscopy advanced as well as the intravascular imaging. I think, you know, the way we did it, we didn't need to use shockwave. We didn't need a drug-eluting balloon. We saved a lot of money and got a great result.
Right.
So you owe us dinner. Sounds like we have one tonight.
Yes.
So,
thank you.
David, thanks. One quick question before we let you go. Did you do lithotripsy or not? No. Okay, and what do you make of the distal run-up? Beautiful proximal vessel, not a very good-looking distal vessel. Should we worry about it?
A lot of years and years and years worth of disease. You're not going to reverse that. What are you going to do? Put metal in that?
No, I'm just asking. Just asking.
Yeah, no, I think it is what it is. We gave some nitro. Actually, is that the last picture? No, there's a picture after that. It plumps up. Can you go forward?
I mean, the question I guess more talking about the distal vessels.
Yeah.
I mean,
give them some flow.
I think this is maybe where DCBs are going to have a much more prominent role.
They're much better. Okay, I stand corrected.
Yeah.
Thanks, guys.
Very good.